Good evening and welcome to Connecting Point. I'm Jim Madigan. Like so many parts of this country, Massachusetts is in the grips of an opioid addiction crisis. Governor Baker says fighting it is a top priority and legislative action is expected soon. Dr. Robert Roose is the Chief Medical Officer of Addiction Services for the Sisters of Providence Health System, and he served on the governor's 16-member working group to identify ways to deal with the opioid problem here. Dr. Roose sat down to talk about that effort recently with Connecting Point correspondent Carolee McGrath.
One of the privileges of being part of Governor Baker and Attorney General Maura Healey's opioid working group was that we had the opportunity to travel around the entire Commonwealth and listen from people, providers, and advocates about what the communities needed in terms of addressing this intense opioid addiction crisis. And we held 4 public listening sessions all throughout the county, all throughout the state, including here in Western Massachusetts and Franklin County. And some of the most sort of striking findings that we found was that, first of all, we need to do a better job in terms of preventing opioid misuse and addiction first and foremost. That starts with education, both of individuals, family members, and medical providers. Because one of the findings that we realized as a working group was that a lot of this crisis originated with the overprescribing of prescription painkillers. Secondly, we also identified that there needed to be better and more accessible interventions. And so we've made efforts to increase ways in which we can screen and identify patients with substance use disorders earlier before they develop more serious problems. Third, there has been a big focus on increasing access to treatment. That means both longer-term treatment beds for patients to continue treatment over the course of weeks to months, but it also means increasing access to outpatient medication-assisted treatment for opiate addiction that can involve methadone, buprenorphine, or naltrexone. That really is the gold standard for this disease, and we realized as a working group we need to do a better job of stitching together the fragmented healthcare system and increase people's access to treatment and support them in recovery over the long term.
And typically, if you could describe the treatment process for somebody who has an opioid addiction.
Yeah, and so it would start with an individualized assessment. And any substance use disorder treatment assessment is one that involves multiple factors, including an assessment of mental health, medical, physical health, as well as social and other sort of economic or other challenges or barriers to treatment. Once somebody is ready and accepts sort of outpatient medication-assisted treatment for opiate addiction, which has the largest evidence base both in reducing illicit drug use, but also saving lives, increasing productivity and people going back to work, and reducing crime, what that means is pairing a medicine that's prescribed by a doctor or another licensed professional along with the behavioral treatment, counseling. So it involves a team working together to address both the medical and the psychological aspects of addiction.
And how do you feel about the governor's proposal to limit the prescription supply to 72 hours? So
when we think about this new bill, what is clear to me that first and foremost is that we are still very much dealing with an opiate addiction crisis. And this crisis, which is taking the lives of more than 3 Massachusetts individuals every single day to opioid overdose, started in large part because of the overprescribing and availability of painkillers. The statute in the bill that limits the initial prescription for opiates to 72 hours is a clear message, as I see it, to limit the accessibility for individuals in the community that might be able to misuse, divert, or develop an addiction to these painkillers. It is clearly a move to work towards preventing more individuals from becoming addicted.
And how about the 72-hour involuntary stay in a hospital if a doctor deems necessary? Is that something that you would support as well?
Yeah, so one of the things about both of these statutes that have been proposed is that the legislature, as well as the Department of Health and Human Services and the Department of Public Health, have been working with medical professionals all along about how to develop strategies to better intervene and treat individuals with opiate addiction. Both of these recommendations, their spirit and some of the language has come out of the work of the Opioid Working Group. In regards to the 72-hour involuntary commitment, what it recognizes is that we already have a process for involuntary commitment for individuals in Massachusetts that are struggling and are deemed to be in imminent danger from their substance use. That is called Section 35. But what that process entails and requires is an individual's family member or a professional to fill out an application and petition the court for this involuntary commitment.
So it takes a lot longer as opposed to somebody coming into the emergency room?
Exactly. Okay. It can sometimes be delayed over weekends or holidays. It also leaves that decision up to a judge as opposed to a physician. So as we have a similar process for mental health disorders, this bill seeks to create a statute that I think is a very bold move in a lot of ways, that moves this into the medical realm to focus not on criminalizing substance use but on medicalizing it, and allows time for individuals to potentially get the evaluation that they need when there's a moment when their judgment or sense of control is impaired.
Okay, so when people get hooked on a pill, often it goes to heroin. I know that there's a newer and a stronger heroin out there. What can you tell us about that?
Well, what we've been seeing and what this evidence is showing, both in terms of overdose deaths, but also in terms of drug seizures from the Drug Enforcement Agency, is that oftentimes drugs that are resulting in overdose is heroin that is adulterated or mixed with a more powerful synthetic opiate called fentanyl. And in 2013 into 2014, we really started seeing this nationwide. And while it's impossible to know until the drugs are tested or looked at back in the lab, what we think is causing a large percentage of the increase in overdose deaths is a more potent heroin, as well as heroin that's adulterated with fentanyl.
How do you feel about Narcan? I know that was a little bit controversial when people started pushing for it maybe about a year ago, but it seems to be that more and more towns are picking it up.
Absolutely. Narcan is 100% a life-saving intervention. It is, if you think about it this way, the antidote to an opioid overdose.
And you don't think it encourages somebody, if you knew, well, my mother has it in the house, you don't think that would maybe let somebody, kind of linger out there a little bit more?
I don't think it deters people from accessing treatment. I mean, we know that addiction can impair people's judgment and their sense of control. But when we're talking about saving somebody's life, I would want that Narcan in every room in the Commonwealth if somebody was there and wasn't breathing, so we could reverse them to give them a second, a third, or a 10th chance at accessing treatment.
To get into recovery.
Absolutely.
I know you had mentioned the overprescribing of prescription medications, but what are the other reasons, do you think, that we're seeing such an explosion of this opioid addiction?
It's a good question, and a lot of factors, I think, play into this. Sometimes there are risks about people that are inherent to families or people that put somebody at risk of addiction. Certainly, we know with heroin addiction now, it started because of the availability of prescription opiates. There's really a direct correlation. Individuals who misused prescription opiates have a 40 times greater chance of becoming addicted to heroin than somebody who did not. There are many other things that influence the risk in sort of the social and environmental factors. Some of those things could be experiencing trauma early in life, lack of access to employment and work, and so things that give people productivity and meaning may continue to increase the risk or set a community up to experience such tragedies.
Dr. Roose, thank you so much for joining us. We could talk for another 3 hours about this. It's a very important topic, and we appreciate all the work you're doing.
Happy to be here.